So when you talk about strategies for clinical management, a couple of things here. These are the strategies that Don gives in his lecture. The difference between, so basically this is kind of a, it's not a real interesting part of it, well it could be I suppose depending on who you are, but the difference between, these are what he would set up on the sensormatics, okay? These are kind of the guidelines. The bronchotron, typically you won't be able to have the hertz or the frequency. It just doesn't, it can't do it all. And so we usually, I say sacrifice the hertz or the frequency. So I'll point out kind of what we run on the bronchotron. So if you've got a baby with hyaline membrane disease or diffuse alveolar disease, a preterm baby, if you went to pick up that baby and was on conventional ventilation, you can expect that you would want to put your mean at about 1 to 2 above what is on conventional. That's where you can expect. Now the caveat in that is, in the transport setting, we went through all these gyrations of, okay, if they're handbagging, figuring out what your mean is. And so there's that little formula. Can you rattle off that formula for me? Okay, nobody has been able to rattle off that formula yet. Okay. I think it's your PIP minus your PEEP, and then your I time divided, okay. But we did that. We'd get there and we'd calculate it out because as nurses, if there were, I don't know what their mean is, so they'd say, we were bagging about 30 on 5 and a rate of 60, so we do our little calculations, okay, this is what mean they're using. But it just became much easier to say, little preterm babies start about 8 to 10, and bigger kids, we start about 10 to 12. Most of the time, that's shooting low. But at least if we start there, our goal is to not over-distend these babies. Because in the transport setting, our protocol is we put them on the high frequency, wait a few minutes, we get our x-ray. And then all of our other treatment is based on that x-ray. And we prefer to have them, even if, at least I would prefer to have them even a little underdistended, so I know I can move up, versus the overdistended, how much do I need to come down? So, little kids, we usually start 8 to 10. I'm just going to make it easy there. I didn't make it quite so easy last night. So, but what this does, if you walk in and your little baby is on the conventional ventilation and they have them on a mean of 14, you punch in that bed and they're on a mean of 14, I'll still start at 8 to 10 and then move my way up. That way I just know kind of where I'm at and how this baby's doing. So the frequency on these little ones, we tend to use hertz of 9 to 10. We don't go on this bronchotron much over 10 hertz. Occasionally, somebody will take them up a little bit higher, but for the most part, we 10 hertz or a frequency of 600. And your delta P, your amplitude, and this is something I didn't understand until later last night. Do you guys do any of you work in the unit? Are you familiar with babies and chest wiggle? Okay. So your delta, your chest wiggle is going to be minimal. It's not going to be a huge. I kind of talked last night about 3. You've got your minimal chest movement. You've got a little bit more than that, and then you got your good wiggle that you would see like aspiration. So you would have some wiggle there, but it's, you've got a little bit of movement in that belly, and that's kind of what you want with the diffuse alveolar disease in the preterm baby. And that's kind of the picture we're talking about. In the near term, you're actually going to expect that you would have to be 2 to 4 higher than your conventional ventilator. But on the bigger kids, it would start 10 to 12 on the mean, and then move the way up. So if I see a baby that's on a mean of 14 or 16, I can expect I can start. But it wouldn't at all surprise me if I have to go higher on the mean. And actually, doesn't at all surprise me when they come off conventional to have to go up higher. Sometimes you're up to 18 and 20 for a few minutes. They open up, they start oxygenating, and then you can wean that mean down. Okay. Questions? The bigger kids on the bronchotron, you can use a hertz of 10 if it's working for you. And when I talk about what you use, the reason I'm specific about you may or may not be able to 1 hertz to 10. It depends on how much amplitude you're needing. If you're needing a lot of amplitude, you have so much gas going to the bronchotron. And I know Phil was here and he went over how it works. So you've got a lot of mean or you've got a lot of amplitude, you're not going to be able to maintain a high hertz and that amplitude. That's why we say, if you can't get the amplitude that you need, you're going to have to turn down your frequency to achieve that amplitude. It goes somewhere, and you have to divide it up where you need it. Am I making sense? Okay. So a lot of times, baby that's 36, 38 weeks, and I usually will start my hertz around 8. 8's a nice number for me, 8 to 9. There are those people who come out of the unit, and they'll try to run the bronchotron at 10 hertz, and sometimes on the not so sick kids it works fine, but sometimes they have to drop the frequency. And that's the picture we're talking about there. On your phobias or your pneumonias, you're going to look at a mean about 1 above conventional ventilation. Again, your hertz are going to be somewhere, you'll find on the bronchotron somewhere between 7 and 10. And you're going to have a little bit more chest movement, more amplitude than you would on your diffuse alveolar disease.